Good morning, everyone, and happy Halloween. This is Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled A Primer on Harm Reduction and Medication of Addiction Treatment with Dr. Erin Madden and Mindy Vincent. FADA's program for facilitating medication-assisted treatment for substance use disorder is funded by the Florida Legislature as administered by the Office of State Courts Administrator. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and myself, the host, by using the chat panel instead of the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may think of as they come across, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer, and if you experience poor audio, there are a few options that you can try on screen, and these options are posted in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and be able to view it on screen as well to receive a certificate of attendance. Again, you must be connected to the audio and be able to view it to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. However, we do have the materials posted today, so if you want to go on our website and print those ahead of time, you can go ahead and do that. The archive video displays what looks like to be an error message, but it's only a delay buffer. So to access the recording and PowerPoint, you would go to our website, www.fada.org, and our Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families and the Office of the State Courts Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close on midnight, Friday, October the 30th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and mental health counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please include your Florida license number for reporting to CE Broker when you registered. Please note that WebEx does monitor your arrival and departure, and it provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to give partial credit. And with that being said, I'd like to introduce our presenters today. Dr. Madden is a faculty member in the Department of Family Medicine and Public Health Services at Wayne State University School of Medicine in Detroit, Michigan. Her research explores substance use among marginalized populations, which include people of color, low income, and rural populations, and social factors affecting healthcare for people who use drugs. She has published research on primary care programs for people with co-occurring mental and substance use disorders, racial and ethnic differences in naloxone prescriptions, and professional attitudes towards medications for opioid use disorders. Dr. Madden received her doctorate in medical sociology from the University of Wisconsin-Madison and her Master's of Public Health degree from the University of New Mexico School of Medicine. And now Ms. Vincent is a licensed clinical social worker specializing in mental health and addiction treatment and is the founder and executive director of the Utah Harm Reduction Coalition. She started the first legal syringe exchange in the state of Utah and has done extensive work in harm reduction, drug policy, opioid overdose prevention, awareness, and treatment, and continues to work to educate the community, stakeholders, and policymakers about the therapeutic substance use and harm reduction. Ms. Vincent is certified in psychedelic-assisted therapy as well as several other cognitive, behavioral, and trauma therapies. Mindy is also the host of the podcast Therapeutic Madness and owns a private practice, Life Changes Counseling, in Heber City, Utah. She received her bachelor's degree from Utah Valley University and earned her master's of social work and her master's of public administration from the University of Utah. And now I would like to welcome our presenters, Dr. Madden and Mindy. I will turn the presentation over to you. Dr. Madden?
Yes, I was just, are my slides going to come up next? I still see the intro slides. There we go. Thank you, Karina. Okay, so thank you for that introduction. So we're going to be talking today about harm reduction as well as medications for addiction treatment, or MAT. Karina already gave a pretty long and detailed bio about myself. I'm an assistant professor at Wayne State University in Detroit. I just left a position at University of New Mexico School of Medicine, where I was a faculty member in internal medicine. And I wanted to also offer Mindy the opportunity to add anything else about your background and introduce yourself. So go ahead, Mindy, if you'd like.
I feel like the introduction. I'm just Mindy from Utah.
Yeah. Great, thank you, Mindy. Okay, so we'll just go ahead and get started. So I just want to start, this is common practice for us. When medical school, we just want to make sure we are clear that we have no conflicts of interest to report. There's no special funding behind this presentation. So I first wanted to ask who's in the audience. I want to ask about your professional roles. So this is an option for you to answer a poll question. We wanted to know what best describes the roles of those of you in the audience. Are you a substance use disorder treatment counselor, peer recovery specialist, medical staff, etc.? So we get a sense of who's out there, who's listening, and who's in the audience. If you could take a moment to finish that. So while that goes on, I can tell you a little bit too about actually how Mindy and I met. We mentioned this to Karina and your organizers. So I gave a harm reduction training in Utah once, and in attendance was a lot of people who work in harm reduction, such as Mindy, as well as some people who work in law enforcement, the county department of health, and people who worked at methadone facilities, etc. And Mindy was so engaged and actually offered so much great information about doing harm reduction work that we decided from that point on that we would do these trainings together. So we've been doing types of harm reduction training since then. That was, Mindy was at 2019, I think it was.
We still have a few.
It might have even
maybe it was 2018. I'm not sure. So
we still have a few.
Everything's been blurred ever since.
So we'll give you 15 more seconds to respond. There's a few that haven't responded yet.
Great. So it looks like the biggest representation is substance use disorder treatment counselor, but that there's a pretty good variety of people in the audience. Thank you for responding, and if you did not answer, that's okay. Some of you maybe are a different role and didn't want to click something else, which is fine. Great. So welcome, and we're so glad to have everyone here. So let's get started. So the outline of the training, we'll start with talking about some terminology. I'm going to go over some data and trends for national, particularly opioid data, as well as some Florida-specific data. And then Mindy's going to take over for a little bit, talking about what is harm reduction, going over 3 of the major harm reduction interventions that we use. Then I'm going to talk about medications for opioid use disorder. I'll mention some for alcohol use disorder, but I'll focus on those that are used to treat opioid addiction. Then I'll talk about some barriers to services, both barriers to medication treatment and harm reduction. And then we'll talk about this idea that harm reduction and treatment can actually be complements. And so Mindy and I will both talk about that, and then invite you all to also provide some of your feedback on that topic. So we'll start with just some terminology, data, and trends. Many of you are maybe aware of this, but we have sort of done a shift in the addiction medicine field related to how we talk about substance use and how we talk about addiction. So when we talk about the use of illicit drugs, in the past we used to use the word abuse a lot, substance abuse. And many of our organizations still have that in it. SAMHSA, has the word abuse in it. The National Institute of Drug Abuse, NIDA. So we still have that word abuse around, but there's been a lot of criticism about its appropriateness. People are abused, Are substances really abused? A lot of people would say not really, So we've shifted to use the term substance use instead of substance abuse. And also when we're talking about maybe someone's urinalysis results, we don't tend to prefer the words clean and dirty, that those might be stigmatizing words, but instead maybe talking about for urinalysis substance use or substance free. When talking maybe about syringes and needles, we would use unused or used. Mindy actually was someone who informed me of that change. So there's sort of new terminology. The motivation for this is to reduce some of the stigma around language. If there is research that shows that the words we use related to substance use do matter and that they can make people feel stigmatized. And if people feel stigmatized, they're less likely to engage in treatment. So we need to be careful of how we use our language. In addition to changes related to the use of illicit drugs, we're talking about people with addiction diagnoses. Of course, we still sort of use the word addiction. Some people have a problem with that word too, but it's sort of less controversial. But now we tend to focus on using the DSM-5 language, which instead of saying there's drug dependence, drug abuse, or a drug habit, we use the term substance use disorder. That no longer differentiates between people who would maybe be classified in the past as fitting into the drug abuse category and then separating them from people who would be classified as the drug dependence category. So everyone's sort of under the same substance use disorder or SUD umbrella. And then within that, you might have particular types of substance use disorder. So opioid use disorder, alcohol use disorder, et cetera. And then when we're talking about individuals who use drugs can refer to themselves however they want, of course, but us as professionals, there's been a shift away from referring to people as addicts, abusers, or users to instead using what's called person-first language, so saying people who use drugs, people who use opioids. Sometimes you can substitute client or patient, that's fine, but sort of centering the individual and their personhood ahead of sort of their behaviors and their diagnosis. So many of you are probably aware of that, but these will be the terms and the type of language we're using as this new terminology in this presentation. So when looking at recent trends related to opioids and overdose deaths, I think it's often helpful to look at the state's data where I'm doing my presentations and compare that to the US rate. So Florida is a darker color, it's a green, it's kind of hard to see. So Florida's opioid overdose death rate here is mapped, charted in comparison to the US opioid overdose death rate. And we're looking at data from the CDC between 1999 and 2018. Unfortunately, that's the most recent data they give the public access to. So we don't have the 2019 or the 2020 data yet, but we will soon. What this shows is that, right, Florida is similar to U.S. death rates in terms of opioids, that are both opioid overdose deaths due to prescription or non-prescription use. And that we see is that, the Florida rate is a little bit, is above, right, the U.S. rate, but just by a little bit. And then there's sort of been some shifts, oscillations between the U.S. and the Florida rate, but that both are kind of still trending upwards. Unfortunately, you see between 2017 and 2018, a slight dip in the national and the Florida rates. We expect that to be pretty much reversed during COVID. Initial data during COVID shows that opioid overdoses are increasing in 2020, since the pandemic especially. So when we talk about opioid overdose, we often mix data together, but in terms of types of opioids, we say, oh, if it's heroin, if it's prescription opioids, we put it together in those opioid overdose death graphs. But it's actually really important to think about which opioids are driving changes in overdose deaths. And what we see from the CDC national data is that there's been what's called 3 waves of opioid overdose deaths. And this means that the types of opioids responsible for the most overdose deaths have changed over time. So the green line at the top is just the overall opioid overdose death rate. What the purple line slightly below that for the first few years is prescription opioids, commonly prescribed opioids, so things like Oxycontin. And that was sort of driving for a long time, so 1999 through about 2010, that was driving the opioid overdose deaths. Recently, the role of heroin has increased as we've sort of tried as a society to get a control over how much opioids we're prescribing by doctors. What happened, though, is that a lot of people were already physically dependent and then wanted to continue using opioids. They were cut off from their prescriptions, so people turned to illicit opioids like heroin. So the first wave is commonly prescribed opioids, fueling opioid overdose deaths. The second wave, between about 2010 and 2013, 2014, is deaths largely being driven by heroin overdose. And then since about 2013, 2014, we've seen the third wave, which is synthetic opioids like fentanyl that are often accessed through illicit drug markets and not prescribed, because of course fentanyl can be prescribed. That this is what's fueling the third wave of opioid overdose deaths. Synthetic opioids are responsible now actually for more opioid overdoses than any other type, and that's been true since 2016. So I wanted to do a quick poll. So of course that graph is the national trends. So those CDC data represent the national trends for opioid overdoses. I wanted to ask, do you think Florida's opioid overdoses follow the same pattern? So you can consider saying, yes, I think heroin and synthetic opioids have increasingly caused Florida overdose deaths in recent years. So that would say, yeah, the role of prescriptions is down, and these illicit opioids are really fueling the opioid problems in the state. Or you might think, no, Florida overdose deaths are still mostly due to prescription opioids. So I'd love to see what everyone thinks about this topic. So maybe while we're answering the poll, I'll just give a little bit more detail on why people think the opioid overdose death rate is going to go up a lot during COVID. Some of you probably are familiar with this conversation, but the initial data from small samples, so looking at maybe just a county or just a state, because that's all we have right now. The CDC takes about a year to give us the national data. But what those initial sort of small studies are showing us is that during COVID, people are at increased risk for overdose. We're seeing more total number of overdoses because people are more likely to be using drugs alone, which means there's no one around to deliver Narcan or naloxone. We'll talk about that more later. In addition, people sometimes are having trouble keeping up with their medication treatment, which makes them more likely to relapse. And then they're using, illicit market opioids, which are more likely to be tainted, unknown strength, right? They might think they're taking pure heroin, and instead they're taking much stronger fentanyl, and that's contributing to overdoses. So there's complex reasons why this could be happening. Access to medication and using alone are the two most commonly thought reasons why. So I just wanted to add some detail on that. Mindy, if you have any other ideas about why the COVID deaths, overdose deaths might be going up, you can also feel free to unmute.
I always have thoughts about everything.
Great.
I also have a question, though, while I'm unmuted really quick, and maybe the Floridians know this answer. I would guess that they do, or maybe you know, Erin, but I noticed on your slide back a couple slides ago that in Florida, like their overdose rate dipped significantly in 2013 and 2014 and then went back up. What did you guys do in 2013 and 14 that did that? I was wondering. But also, I think people just being so isolated. People who are not even alcoholics are now alcoholics because of coronavirus. Imagine people who have significant substance use disorders, how many opportunities have presented for relapse, you know?
Excellent point.
So,
yeah.
It's not for yet. So, but I would really like to know what happened in 2013, 2014 that made Florida's overdose rate dip so much, if anybody knows.
Yeah, if anyone wants to add into the chat, maybe your ideas about what happened during that period, good catch, Mindy. That is like a reversal of the trend that we saw between 1999 and 2013. There was then a dip below the U.S. rate, and then around 2016, 2017, it rose above that national rate again. Great question. So we'd love some insight on that. So let's look at the poll results. So most people think yes, heroin and synthetic opioids like fentanyl are driving the most recent years of overdose deaths in Florida, similar to national trends. A few people think no, that is probably still prescription opioids driving the majority of it. And I want to thank Mindy for pointing out that, yes, the social isolation of asking people to quarantine, of asking people to socially distance is really difficult, and that absolutely can contribute to overdose. So I'm going to just show us the Florida data. So this is from the same CDC database, just looking at Florida's trends. And so they represent it slightly differently. So the bars are that all opioid overdose death rate, the same as the green line in the previous graph. What we see is that the yellow line is synthetic opioids like fentanyl, and that since about 2015, 2016, that has spiked hugely and is now responsible for more opioid overdose deaths than any other type of opioid. Prescription opioids are the second most important, and there is an increase in heroin. Heroin has not surpassed prescription opioids, but if we were to look at synthetic and heroin together, which we would group them as illicit opioids typically, that those are really what's driving Florida's opioid overdoses together since about 2016. So did we get any responses to the discussion? Yes. Great.
Yes, we have several comments, and then I just wanted to remind the audience whenever you're posting your questions and comments to please put it to host and presenters or all panelists, so that everyone gets it. Some of the comments that we got were we shut down our pill mills, the Pam Bondi initiative, meth use increase, maybe they busted some pill mills, crackdown on pill mills in Hillsborough. One of the biggest providers was arrested and prosecuted during that time, and then prescription drug monitoring legislation.
Excellent. Thank you for that feedback. That makes a lot of sense. Prescription drug monitoring programs, PDMPs, are really important, of course, for reducing prescription drug overdoses. Absolutely, that's an effective intervention. And then the sort of addressing overprescribing or unethical prescribing among physicians definitely could be part of it too if the state did that on a big scale. So thank you for those responses. That makes a lot of sense. So I'm going to move on and talk about access to care, access to treatment. So this is national data again, but it shows that, there's about 2 million people as of 2017. It's gone up a little bit since then, but about 2 million people with opioid use disorders across the United States. And I want to point out that this graph on the left side is showing what percentage of those people received treatment in the past year. Only 34%. So, of course, that means 66% of people with a diagnosed opioid use disorder in 2017 did not receive any treatment. And some people might say, well, a lot of that's people being uninsured. But these bars on the right side show that actually even among people with insurance, so Medicaid or private insurance, you don't see great treatment rates either, right? So the group that's the most likely to get treatment is actually Medicaid patients. Those with private insurance are very, very below even the overall rate of receiving treatment. And uninsured people are actually more likely to have gotten treatment in the past year than people with private insurance. So we're going to talk about some of the financial barriers to treatment at the end, but I wanted to ask a question to the audience that we're sort of going to be grappling with today, which is, so what can we do? So some of the barriers are not just financial, but sometimes people don't want to go to treatment. So what can we do to improve the willingness and ability of people with opioid use disorders and other addictions, of course, to get treatment? And for people who refuse treatment, what should we do? So this is the sort of, that second question is a lot of the population that Mindy works with is people who are not necessarily ready for treatment. Some people are, who she works with, of course. But, one approach to improving people's willingness to engage with treatment and also to help people who are not necessarily interested in stopping drug use is this thing called harm reduction that we're going to be talking about today. So I'm going to hand this over to Mindy, and she's going to talk about what harm reduction is and give a great overview of her work and all the interventions that can be done that are harm reduction interventions.
Hello again. So I'm super excited to be here, and I'm already loving this presentation so much because the information, although, some of it is the same, looking at it from a different place is really interesting. Until you guys, that feedback started coming from my question, I had forgotten that Florida has a long history of really bad prescribing and actually some very frightening treatment and sober living situations down there. So I can't believe I forgot about that for a moment. So yeah, very interesting to look at Erin's data from down there. I can't wait to look up some of your policies. Anyway, in the meantime, we'll talk about harm reduction. So I don't know how many people here are familiar with harm reduction, but harm reduction, it has no single definition, although most of us who are practicing harm reductionists do go with the definition that is on the National Addiction Coalition's website, and it has different interventions. So you can always look up a lot of information about harm reduction there. They're an excellent resource. But it's a set of strategies that are aimed at reducing negative social and physical consequences associated with drug use, which includes death, disease, homelessness, lack of work, poverty. I mean, the list goes on and on. There's so many things that when people are in active addiction that we can help them with harm reduction. Harm reduction is also a movement for social justice, and it's people who use drugs have the right to be treated with health and dignity and have the right to determine what they want to do. And just there's a lot to that, and there's a lot of work we need to do in our field to shift some really embedded stigmas and biases that are harmful to people. And also people use, we use harm reduction in everyday life, right? Like if you wear a seatbelt, you're trying to reduce your harm. Sunscreen is harm reduction. There's so many that we use every day. So when you think you are not a harm reductionist, step back 1 second and look at it. So harm reduction strategies, incorporate strategies to meet people where they're at. My favorite thing that we say as harm reduction is we meet people where they're at, we don't leave them there. I'm a social worker. It's interesting because it's doing, when I do harm reduction, specifically syringe exchange, that seems to be the one that people think is enabling. But when I do syringe exchange, people seem to think that we just high-five people and say, oh yeah, we heard there's good dope around, enjoy. And that's not the case at all. I know for a fact that there are people who leave syringe exchange, go around a corner and die in an alley somewhere. I know that I am sometimes, me or my staff are sometimes the last human contact that people have before they die. And if we didn't take that opportunity to change their lives, then we have no reason out there. So we do meet people with that, but we absolutely try not to leave there. like me promoting safer use. Oh, yes.
I just wanted to find out if there was something. It seems like something's going on with the audio with you. You're coming in and out.
Interesting.
I didn't know if you were doing something different.
Mine says I have a strong connection.
Okay. So we'll just keep going. I just wanted to
I don't
let
know.
you know.
Okay. It says I have an option to switch audio, but I don't know what that would be too, so that's a little bit scary. Okay, so my audio is in and out. Why is that? Okay, well, if it keeps doing it, then maybe in between my slides, we might have to see what we can do. Maybe I can call in or something. I don't know. So harm reduction. Oh, I'm sorry, what?
You can call in if it continues.
Okay, perfect. Okay, so if it continues for much longer, someone let me know so I can just call in instead. So harm reduction does mean promoting the safer use of substances among people who still use substances, because one of the basic tenets of harm reduction is that we accept, for better or for worse, that substance use occurs. And there's actually nothing wrong with substances in themselves. It's how some people use them. And so we accept that that's just a fact of life. And instead of believing that we can eradicate substance use, we believe that we need to keep people safe if they are going to use. But as a harm reductionist, we also support abstinence. Abstinence is the one side of the spectrum of harm reduction, where chaotic use is the other side. I myself got sober through abstinence-based recovery, through 12 steps, and through drug court. I'm actually a graduate of felony drug court. So I absolutely support all of those means and methods. Whatever works for a person is what we should be doing. Harm reduction strategies are considered evidence-based practices. They have been going on for decades. Syringe exchange started in the Netherlands in the 1970s, and it's been actively going in the United States since the 1980s. If you were to talk to the CDC or the World Health Organization, they would both report that syringe exchange was the single biggest factor in eradicating the AIDS epidemic. There's lots of research on harm reduction in general. It does in deaths, and there is infectious disease, and HIV. Also, there is a huge reduction in drug-related injury, like abscesses, soft tissue damage, things like that, bacterial infections. Harm reduction is absolutely endorsed and encouraged by the World Health Organization, the CDC, NIDA. They all endorse syringe exchange, which is interesting because federal funding blocks most spending towards syringe exchange. So what is not included in harm reduction? So punitive policies, they actually create more harm. They're not part of harm reduction. Oh, I myself, I got to go through drug court. I went through drug court because I'm a high-risk, high-need offender. I had real crimes that were committed because I was on drugs, but they were real crimes that needed to be addressed in a court of law, right? So in that case, it was appropriate for me. But for the most part in this country, we use the criminal justice system as access to treatment, and that's just outright wrong. And we're creating so many more problems by sending people to jail or prison, taking away people's children. I'm a social worker. I believe in protecting children. However, DCFS, our child welfare systems are broken in most states in this country and cause generational substance use, poverty, and all sorts of other things. So we need to really be looking at these interventions that we're using and saying, hey, is this causing more harm than good? Taking away people, if you haven't seen the research, drug testing people, I think Florida is one of the places that did it. Tried drug testing people who were receiving welfare, that were welfare recipients, and it was a huge waste of money. I know for sure Kentucky wasted a bunch of money doing it. And expectation all people should achieve abstinence, that's not harm reduction. Although we do support abstinence, everybody needs to stop using everything. There are people who continue to drink alcohol normally that need to not use heroin. And that's one of the things of harm reduction, too, is the base successful interventions based upon the person's goals and what the person wants, because it's truly person-centered. And the belief that people who use drugs have to hit rock bottom before they can be helped, that is not only not harm reduction, but it's dangerous. And rock bottom for many people is death. No one deserves to die because they use drugs. And I think if somebody believes otherwise, they probably shouldn't be in this field, at least, because we have to save lives. We can fight about the rest of it later. Can you guys hear me? Like, is the sound still cutting out, or is it working?
It's working for the most part, but you do cut in and out. And I did send you the call-in information. So during polling, if you want to do that, that would probably be better.
Okay. All right. That's what I will do when we get to polling. Okay. So the 8 key principles of harm reduction that are outlined by the Harm Reduction Coalition, as I talked about these a little bit earlier, the drug use is part of our world. We want to minimize its harmful effects rather than just think that it's not going to happen. Understanding that drug use encompasses a continuum of behaviors. Like I've said before, it's a spectrum from chaotic use to total abstinence. There are some ways that drug set and setting is very important. What kind of drug somebody's using, how they're using it, where they're at, all those things are addressed in harm reduction. And they carry a lot of weight as well. So establishing the quality of life and well-being, not necessarily abstinence, as the criteria for successful interventions and policies. Harm reduction requires non-judgmental and non-coercive provision of services and resources, which is really difficult when you're trying to implement harm reduction programs, because the mindset throughout our country is so rooted in punishment and abstinence that people are like, well, so then what are you going to do to get them into treatment? So do they have to do this in order to get syringes? Like, what else do they have to do? What can we make them do? And that's not harm reduction. And it actually diverts people from using safe services. Thank you, Daryl. And it ensures that people who use drugs routinely have a voice in the creation of the policies and programs that are designed to serve them. You will often hear in harm reduction the saying, nothing about us without us. And one of the things that I love about this is, I love to get feedback from my participants who are actively utilizing our services, of course. And I also love substance abuse, because of the fact that there are so many people who have recovered from substance use, myself included, that and we give back and we do something, so we understand what some of these needs are that need to be met, and we're also in a better place to be able to help carry them out. So I love that. It's one of my favorite things about harm reduction. So people who use drugs are their own primary agents of change. Anybody who is a practicing clinician knows that shame only changes behavior short term, if at all. And so if we empower people to make their own change on their own terms through the stage of change, our efforts will be futile, and we also could lose a life. So empowering people to make choices is the best thing we can do. There are a lot of things that play into substance use. Poverty, racism, social isolation, trauma. There's so many things that play into whether somebody, how vulnerable somebody is to become addicted, as well as their ability to get sober or to even make life changes. And also, I think people have to take into account that all human beings are also different. So even though people may have similar experiences, their responses to those experiences are not necessarily the same. And one of the greatest injustices that we do to people who are in active addiction in this country is withhold important things from them and tell them, if you just jump high enough, if you just do this, you got to get housing out of prison, right? You've got to, you can't get housing, you can't get a job. It's very difficult. Like, for me, I'm a convicted felon. If I didn't have a house, it'd be so hard to get housing because I can't pass background checks. and those things all affect people's ability to be able to maintain long-term recovery or to recover entirely. And so we have to address all of those things, and if we're not really helping people. Also, we do not attempt to minimize or ignore the real and tragic dangers associated with illicit and illicit drug use. Not only was I addicted to substances for 17 years, and I lost my whole life through that over and over again, but I lost my big sister 6 years ago to an opiate overdose, and that's how I became a harm reductionist, and, because I couldn't get her back. And so the best thing I could do was try to keep other people alive, try to help these people to stay alive so that you don't have to bury them. And so people think that I don't understand the dangers of substance, they don't know anything about story. And I take every opportunity I have to express those to my clients. I see them at the syringe exchange, I snap them up quickly. And first I give them a hug and I tell them I love them. Then I tell them that they clearly, because so often they are picked up, picked all over and stuff. And I tell them, you got to do something different. What can I do to help you? This is not okay, and so, acknowledging the harm of them is, while also recognizing them as a very big deal in harm reduction. And it's a myth that people think that we don't recognize the dangers of substance use. Oh, here's a poll question. And if you guys need me to call in from this point on, tell me, I'll call in. Okay, so right now, your feelings about harm reduction are positive, neutral, or negative. You feel warm and fuzzy? You feel like, or are you like, absolutely not? All the feelings are valid.
I think Mindy should maybe call in just so we don't, it's very minimal what we're losing, but we do lose like a second every once in a while.
Mindy, if you go up to your menu where it says audio and video, you can select switch audio, and it'll give you the call-in number.
Okay.
Yeah.
So I also just wanted to add about the last principle, that yes, as someone who does research on harm reduction and medication treatment, that I often get accused of enabling people or sort of thinking that drug use is totally not a problem, who cares? And that's absolutely not the case. Everyone I know who works in harm reduction, who I do research with related to harm reduction, who does harm reduction services, all of us have lost people. All of us have literally had people in our lives die, and we just want to make sure that doesn't happen again. So I always think it's an interesting accusation because, if anything, I feel that we are the most desperate to make sure that people don't die and to make sure that people's drug use does not become a fatal problem compared to anyone else I've met. So I just wanted to add that number 8 is really a common misperception, and being on the inside here of the harm reduction world, I can't think of any other sort of accusation that is less true.
Thanks, Erin. I agree with you. Okay, can you guys all hear me? Can you hear me better now?
You sound
Hello?
good.
Oh, okay. I was like, I'm not hearing anyone now. I think they don't hear me at all. Okay, so has everybody had a chance to fill out the poll? I don't know how to make the answers come up, so.
They should show up now.
There they are. Oh, that's so nice. There's not a single negative answer. That's really wild. I live in Utah, and that has never happened here. We've never had, usually half the people are like, ugh, harm reduction, ugh. Okay, so let's continue. So these are some harm reduction interventions that are either implemented or we're working to implement here in this country, and they're implemented in other places in the world for sure. We'll get there though. So one of my favorite ones is safe consumption sites, or as we call them here in Utah, overdose prevention sites. They're also called safe injection sites, but really the most accurate name for them is overdose prevention sites because that is their primary goal. Over 10 million injections have been done in just the one in Canada that's in Vancouver. It's called On-Site, and over 10 million injections have been done in that one alone, and no one has ever died from an overdose in an overdose prevention site in the entire world. I have visited the ones in Switzerland, which the first one was opened in 1994 in Bern, Switzerland, and people are connected to a lot of resources. Like, you don't just walk in and say, hey, I'm just here to shoot heroin. Like, that's not how that works. You come in, you're enrolled. They do, like, basically a biopsychosocial with you. When your number comes up, you go to a little medical, it's like a cubicle that's medical, and you do your substance however you do it. They have different areas for different places. That's why I don't like the name safe injection sites either, because people go there and safely use substances in many ways, not just through injection. But they are able to provide immediate response to overdose or any other complications that come. They work with other providers to ensure that other needs in these people's lives are being met, that children are being properly cared for, that they're being able to access treatment if necessary. It creates a place where sex workers are able to have conversation about johns and places and stuff that are not safe. So they're able to provide like sex worker harm reduction in these places as well. But mainly the most important thing is it provides connection, ensuring they're not going to die. So this here is a picture of a safe consumption site. This is the one in Montreal, Canada. The ones in Switzerland look super similar to this. And it's weird, too, the one in Geneva, it's right smack in the middle of the city, and it's a bright green building, and I never would have thought that was a safe consumption site, but they're nothing like what you would think. They're not dirty, and there's not, like, all the things that people think they're going to look like, they're not like that at all. So are they legal? Sort of. My friends in Philadelphia, they planned on opening Safe House, and when they were going to open it, the feds filed a suit against them. They filed an injunction saying that they were violating the crack house law. Safe House actually won that case in federal court, but the feds appealed, so now it's going to a higher court. But so far, they've won. So they actually could have that one open, but they don't because there was so much pressure from people in the community toward the landlord of the property that he pulled out. So they're looking for a new location. Are they effective? Yes. As I said, they're actually the single most effective thing for overdose prevention that we know, besides outright abstinence, because no one's ever died in a safe consumption site. And they increase treatment referrals, they decrease disease transmission, they decrease drug injury, they increase medical access because people are not going to walk in with an abscess and the staff say nothing. And we are actually running a safe consumption site law here, an overdose prevention site law here in Utah for the second year. This year it's about to enter into our legislature again. It probably won't get passed, but I have other ideas for how to get it through. They've also legalized it in Denver, San Francisco, and Seattle, but they haven't been able to get them open. So safe drug consumption sites that were established in Sydney, Australia. In the first 18 months, over 4,000 people registered. There was over 55,000 injections done. 1,400 people were referred to treatment and social services, which I think that number actually can go up. From being a provider myself, doing syringe exchange, we always provide written or verbal referrals for certain things, and so I think that number can go up. 409 overdoses were attended to. None were resulted in death. Community members actually over time came to support these because they were adamantly against them in Australia, and they opened them anyway. And the community actually, after a year and 18 months, community started getting together and asking for more safe consumption sites because of the positive effects they had within the community. So syringe distribution programs, they are also called syringe exchange programs, syringe service programs. That's what our health department prefers to call them because they're not just syringe exchange. There's so many other services with them. But we provide free unused syringes and other items that people need to safely inject drugs. So that means cookers, tourniquets, cotton, sometimes saline water, or not saline water, but sterile water if we have it, or saline water. Whatever things we can provide to people to help reduce their risk. We give naloxone to all of our clients as well. So it's usually an exchange, and it can look different depending on where you are. Some people require a one-for-one exchange. Some require just one be given, and then you can give however many they need. We do know from research that if the number of needles is restricted that people can receive, that it actually reduces the effectiveness of the program. Also, we know that if people are only given syringes and not given cookers, cottons, tourniquets, that the risk of them transmitting or contracting disease does not go down. They still keep the same risk. But in certain places where we do syringe exchange here in Utah, we're only allowed to give out the syringes. They won't let us give out the kits. So we have to do a lot of education with people about those missing pieces so that we can keep the disease transmission rate down. We also offer, most programs will offer linkages to PrEP or PEP, which is pre-exposure prophylactic and post-exposure prophylactics, which prevent the spread of HIV. We typically offer free hepatitis C and HIV testing. We offer linkages to substance abuse treatment, to detox. We help people get signed up with Medicaid. We try to help people get lined up with housing, but affordable housing is not a real thing here in Utah, so that's one we can't really help with most of the time. Are syringe exchanges legal? Yes, in most places. In some places they're not. And then even in places where they are, like, you know, law enforcement has to be on board with a harm reduction program or they can single-handedly crush it. And so when you have sometimes you have to meet law enforcement in the middle, like we have to in some counties where we can only give syringes. So it's legal, but sometimes the laws aren't made well, or sometimes people have a hard time supporting the law. So you just have to meet people where you have to so you can get the programs going. These are two of my employees. These are shirts. This is at one of our exchanges in Salt Lake. I can tell that they're down on the block by the thing. The block is it's like our Skid Row, I guess is how you would call it. It's now caged. A whole other story. So are they effective? Yes, they are. They reduce HIV and hepatitis C infections. They save tons of money. People who use syringe exchange programs are 5 times more likely to enter into treatment. They do reduce accidental needle sticks in communities. They do not increase levels of arrest, crime. They do not actually increase syringe litter. They decrease it because people need to turn them in. But also most responsible syringe exchanges will send their staff or volunteers out to do syringe cleanups in the areas where they hold syringe exchanges, because I think most of us feel like that's part of our duty to the community, you know. So naloxone distribution. So naloxone, I would guess that most people know what that is. It's the same thing as Narcan. It is an opiate reversal drug. It has been around. Where can I donate unused needles? Francisco, you can send them to me. Or, you know what, you have a lot of syringe exchanges, I'm sure, down in Florida, too. I could get you somewhere down there that you could donate them. Sorry, I was just responding to somebody on the chat. So it's sometimes referred to as Narcan. It comes in a few different forms. You can get it in injectable. It goes into the muscle. There's one that guides you and talks to you. There's the one that goes in the nose. And I thought that this is where it switched to Erin, because Erin is so good at talking about how naloxone works.
I can.
What, Erin? Like,
sure.
Why are your slides with mine? Erin is really good at these slides, so I'm going to let her do these slides.
No problem. Okay. So, of course, all of you know that, you know, when there's an overdose, someone has taken too many opioids. So too many opioids are bonding to the receptors in the brain, which causes breathing to slow. And then, of course, if it's untreated, to eventually stop. So this is just, you know, a visual representation that looks nothing like what it actually is, but just to sort of illustrate that this is sort of the opioids covering the brain receptors. There's too many in there. Mindy, can you advance the slide, Mindy?
Yes. Oh, sorry. You cut out. I was like, what? Mindy, did I what?
So naloxone actually has a stronger affinity to the opioid receptor, so it bonds better to opioid receptors in the brain. So once you take naloxone, it kicks off the opioids from the receptors, and it sits on the receptors instead. So it'll sit there for about 30 to 90 minutes, and that will allow the person to breathe again. But of course, right, some opioids are both very strong, so you need more than one dose of naloxone. You could make sometimes 5 doses if someone's taken a lot of fentanyl. Also, right, some opioids last longer than 30 to 90 minutes. So if someone overdoses, for example, on a prescription opioid that has ER at the end of it, extended release, that opioid is going to outlast the naloxone. So you will have to be ready with more naloxone. The person should ideally, of course, go to a hospital so they can be monitored so that doesn't happen. Mindy, do you want to take it over again?
Yes. Thanks, Erin. I like when Erin does those 2 slides better. So anyway, yeah, and it is really important after an overdose. People oftentimes are not willing to go to the emergency department, but it is important, especially if you don't have any more naloxone, because I have known people who have gone back into overdose and almost died, and overall it took like 6 doses of naloxone over 2 hours to keep them alive. So if you can get people to the hospital, please do. Is it legal? Yes. Ooh, in Florida, you guys have a standing order, and it is effective. It's not effective to reverse other substances besides opiates. It is effective for opiates, but it also, so like Erin was saying, with strong opiates or with large doses of opiates, it can take a lot of doses, and sometimes people don't have that many doses. So that's one thing that you should know about naloxone. Also, depending on who you're distributing the naloxone to, you should try to pay attention to what types of naloxone you have and who it's going to, because like a 50-year-old mom might not be able to keep herself composed well enough to screw a tip onto a syringe and then draw up the naloxone and inject it. So if you have like the nasal ones, maybe those are the best ones to distribute to more lay people. Just my own personal experience, because you don't want somebody to have naloxone and not be capable of using it. And so now we have another poll question, very exciting. Which of the 3 harm reduction interventions do you consider acceptable services for a society or community to implement or provide for people who use substances? So it's not asking how you feel about working in one. Maybe you'd love working in one. Maybe you wouldn't. Harm reduction is not everybody's cup of tea. But of these, which do you think are acceptable for implementation within a community? Ooh, I can't wait to see your answers.
So I was going to add in, so I'm actually from Philadelphia originally, and the neighborhood where they were going to do the safe consumption site or the overdose prevention site is not far from where many of my friends live. It's not where my parents or my brother lives, but they were sort of uneasy about it, even though I've talked to them a lot about harm reduction and the efficacy of safe consumption sites, because they were worried about what I think a lot of people would be worried about who don't know about these interventions, which is, is this going to attract people who use drugs to our community? Are there going to be more syringes around? They were worried about kind of outcomes for their neighborhood that they thought were undesirable. And, sometimes we call that sort of attitude like a not in my backyard or NIMBY, mentality. It was interesting, yeah, because once I sort of talked to them about it, I said, but if we get multiple of these across the city, like someone has to be the first one to go. But if we get multiple around the city, it won't actually attract people to your neighborhood because it'll be in multiple neighborhoods. And honestly, the people are already there using drugs. They're just using them in places where you're not seeing them and that are less safe. So ideally, right, you have a safe consumption site. You have multiple sites strategically placed. And they told me they changed their mind based on our discussion. Who knows if they actually did. But that was sort of one of the problems in Philadelphia, is that they were only focusing on one neighborhood for the site, and Philadelphia needs multiple because they have a lot of substance use issues related to injection drug use and opioids and really high overdose rates. So they need more than one site.
Yeah, and one thing I want to say about overdose prevention sites as well is that, oh gosh, my thought literally just left. It was something to do with the Philadelphia folks. Oh, I'm getting old, people. When it comes back to me, I'll let you know. It literally left the train in the middle of departure or in the middle of loading. Okay, I think we're at our break spot too, though. Oh, I remember what I was going to say. We already have safe consumption sites in this country. They are called bars. People go into bars to safely consume alcohol. And so we have somewhat of a model for safe consumption sites already with alcohol. And people are using substances, whether they have a place to use them or not, right? That's why I said some people access my syringe exchange, and I know they go down the street and they die behind a building. So people are overdosing and using substances anyway. No one deserves to die in a Burger King bathroom or in a porta potty at the local park. And that is the reality of what's happening. And so that's why I personally think that safe consumption sites or overdose prevention sites are so important and crucial, because we're not, it's not a behavior that's stopping. It's a behavior that needs to be sheltered and safe-ened. No one deserves to die in a porta potty.
And I wanted to add, so one of my friends died. He was injecting drugs, and a friend of ours who was not an injection drug user, she decided she would go with him so she could make sure, right, he didn't overdose. And she actually fell asleep by accident, and he did end up overdosing. And I just don't think it's fair to put this on individuals to have these monitoring systems in place, untrained, right, individuals, and then they have to live with this for the rest of their lives if they were not able to save the person, they fell asleep, whatever. I just think that that's a really inefficient public health practice. That should have never been what my friend had to deal with. But there's no safe consumption site in New York City where this happened. So this is the type of things that we also want to prevent, is the trauma of someone potentially not being able to have saved someone who they were around who was injecting drugs. I just can't imagine how she feels, and I know it's probably pretty bad, you know?
Oh, that is so tough. That's such a good point, Erin, because trauma is so often the root of substance use. And your friend wasn't a substance user, but, like, that's the kind of stuff that can lead people to becoming one. Okay, so, Erin, we're at our break point, right? Oh, I'm so sorry.
You should see the results for that poll.
Yeah, I see the results. They look lovely. Good people, nice people. Okay, so Erin, we're at our break, aren't we?
Yeah, and I think, you know, the results of the poll are showing that, like, you know, naloxone distribution is pretty acceptable, syringe distribution slightly less acceptable, and then safe consumption sites, not everyone in the audience feels that that's an appropriate service for their community. And you're allowed to disagree with the things that we say, you know, in this presentation. We're just sort of talking about the evidence for them and why people think that these are a good idea, but ultimately you don't necessarily have to agree. This isn't a test about us changing your mind necessarily. So, but it is our break time.
Perfect.
Okay, so if everyone wants to be back in 5 minutes, we're going to take a 5-minute break. So if you can be back at 12:08, that would be great. Thank you. Erin and Mindy, are you there?
Sorry, Corinne, I stepped out for a second. What did you say?
Just wanted to thank you for reading the results, because they don't see that. So whenever you do the poll, it's a good idea to read the results.
Okay, all right. I'm just going to step out for 1 second. Okay.
Okay, I want to welcome everyone back from break, and Dr. Madden and Mindy, if you guys want to get started again. We do have some comments from the crowd that I don't think we touched base on, so do you want to do that now or continue and do it towards the end? Dr. Madden? Dr. Madden, are you back?
Yes, sorry, I have a dog that was not happy.
Oh, well, that's okay. I think everybody's probably back now, and there are a couple of comments. I didn't know if you were ready for me to share.
Yes, go ahead whenever you're ready.
So this is going back to some things that we were talking about prior from Daryl. This is a great idea, and my wife is working now to begin a needle exchange in the Panhandle of Florida. It would keep the cost of treating HIV or hepatitis C due to using contaminated needles. And then I had a comment, nothing in the past has worked. We've had the worst drug addiction still in this country, and we might as well try something different like harm reduction. And then I think there was a question about how someone can donate unused needles or where.
Excellent. Mindy, do you want to respond to any of that? Mindy, you're not there. Okay, so I can, that's fine. Yeah, so Mindy said there's probably local syringe distribution for services programs to donate to, but that she could help maybe locate those. And we have our contact info at the end. In terms of, feeling like, we've been trying a lot of different models in this country and we have not had very successful outcomes related to substance use. I completely agree. And I think that's why so many people have become sort of interested in harm reduction, not just from, Mindy and I, of course, have personal experiences that drive sort of our interest in this approach, but also people who don't, but just look at the research from other countries, Switzerland, Portugal, Canada, Australia, and they see that a lot of these interventions do improve outcomes. So why not have us try them too? But of course, as Mindy sort of talked about, there's all these legal barriers. And it really is a shift from how we've been approaching substance use in our society, which is largely utilizing the criminal justice system for what is supposed to be, a health problem. But because of the ways that we criminalize substance use, of course, then we have, people doing illegal activities. Mindy talked about, there's times where you've done something illegal and you do have to be a part of the criminal justice system because of that. But there's also times where someone is just using substances and then we're putting them in the criminal justice system for just that behavior alone. And that we really need to think about, is that the optimal sort of intervention for that person? I think international data would say probably not, that these harm reduction approaches work really well. Mindy, if you're there, if you want to add anything.
I think she's off the line right now.
Okay.
I'm trying to reach her.
Great. So if it's okay, we'll just start moving on for the section on medications. Does that sound good?
Okay. It looks like she's joining now, but yes.
Okay. We can come back to it at the end as well. Okay. So I'm going to talk about the part about medications for opioid use disorders, and I'll point out the one medication is also, of course, used for alcohol use disorders, which many of you know. So we're going to be talking about methadone, buprenorphine, and naltrexone. Okay, so I'm sure many of you are familiar with these, but in case you're not, of course, these are FDA-approved medications that are used to treat opioid use disorders. There's multiple ways these medications can be referred to, and they're all correct. There's just sort of been a shift in language recently. So probably most often these medications are called medication-assisted treatment or medically assisted treatment. There has been a recent shift. The American Society of Addiction Medicine has decided that they don't like the word assisted. They would prefer MAT to mean medications for addiction treatment. And then MOUD, medications for opioid use disorders, are just a subset of those medications that are particular to the treatment of opioid addiction. So I can say the reason why they decided for that change in what MAT means is, again, trying to be careful about language and what the language we use implies. So if we say medication-assisted treatment, it sort of implies that the medication is assisting another more legitimate type of addiction treatment, which would typically be, right, psychosocial services, talk therapy, etc. But the medications in and of themselves are a treatment. They should be seen as treatment, even when they're not necessarily used with psychosocial services, which is the ideal model. But it doesn't mean that when someone's taking buprenorphine or taking methadone and they're not using psychosocial services, that they're not in treatment. They are, right? So that was sort of the motivation for the change of what MAT means. Other medications, of course, also exist to treat alcohol use disorders. One of the medications used to treat opioid use disorders is also used to treat alcohol use disorders. And then alcohol use disorders have a few other medications as well. Other substance use disorders do not currently have medication treatment. So if someone's addicted to methamphetamines or cocaine, unfortunately, there's no medication that can be prescribed to them for their treatment. However, I will say there is some pretty exciting research about potential medications for amphetamine use disorders. So there might be some of these in the future, but we're just not there yet. So in terms of the medications used to treat opioid use disorders, they each work in a slightly different way. So methadone and buprenorphine are what's called as opioid agonists. Sometimes they're also called, these two medications as a group are called OAT, O-A-T, or opioid agonist treatment or therapy. And that means that these two medications themselves are opioids. Some of you might think, how can you use an opioid to treat an opioid use disorder? Well, they don't necessarily function exactly the same as heroin or illicit opioids. And I'll say more about that in the next slide. But so methadone is what's called a full opioid agonist, which means it generates the full effect of an opioid. It fully satisfies the opioid receptors. Buprenorphine is what's called a partial opioid agonist. So it mostly satisfies the receptor, but not as much as methadone or a full opioid like heroin. Naltrexone is not an opioid, right? It is the one medication that is not an opioid. It's what's called an opioid antagonist, which means it blocks the effects of opioids. So it covers the receptor without satisfying sort of the cravings and physical withdrawal symptoms of someone who's addicted to opioids. So we'll start with just saying a little bit more about methadone. So methadone is a synthetic opioid agonist. It's long-acting. So here's one of the ways it differs from heroin or fentanyl. It's long-acting, so it lasts about 24 to 36 hours. And during that time, the individual is prevented from having withdrawal symptoms, it reduces their cravings. And so unlike short-acting opioids like heroin, methadone doesn't produce euphoria when it's dosed properly by a physician. Some of you might say, well, I've seen a client who's on methadone who was really drowsy, was sort of almost nodding out. So that can happen for two possible reasons. One is the person, well, actually probably three reasons. So one is the person might be taking their methadone as well as a benzodiazepine, so an anxiety medication. Those two things, when they work together, do produce like pretty severe drowsiness. So ideally, right, the person, if they're taking a prescription benzodiazepine for an anxiety disorder, their doctor would be working together to get the dose right. You maybe saw them when they were working on that, right? Other times, of course, though, people can use benzodiazepines illicitly, so they can buy them on the street or they can borrow, take some from a friend, and that's sort of unregulated, of course, use, and then, that's not necessarily the methadone, that's the mixing of a benzodiazepine and the methadone. So that's one reason this could happen. Another reason it can happen is early in someone's dosing of methadone, you kind of have to work on getting the dose right. Typically, people are dosed pretty low at first, and sometimes to keep their withdrawal symptoms away, they'll have to continue using an illicit opioid, unfortunately. and to stop their cravings and not go through withdrawal. So sometimes they'll have used methadone and they'll use heroin or fentanyl or something else on top, and they're giving themselves too much, and they are kind of like experiencing some level of euphoria. So those are reasons why you might see that. Other times, too, people are just sleepy. And to be frank, people have to get methadone really early in the morning, and not everyone's a morning person. And sometimes people are just sleep deprived, but methadone often gets blamed for any type of drowsiness in any individual. And I would say we should be careful about those claims, because there's a lot of reasons why people might be looking like they're nodding out or very drowsy, and methadone might play a role, but most often it's these other things. So it does block the effects of other opioids like heroin when it's dosed properly, because, right, the opioids, the methadone opioids would be covering those receptors in the brain. Someone could, of course, still overdose if they used a bunch of opioids on top of methadone, so you have to be careful about counseling patients about not using illicit opioids on top of methadone once they're dosed properly. Patients are, of course, actually encouraged to stay on methadone treatment as long as they feel helped by the medication. There's actually we don't know what the optimal treatment length is for methadone. We don't know if it's 6 years. We don't know if it's 1 year. We just don't have the research to make a clinical recommendation for anyone at this point. But we do know kicking people off methadone or encouraging them to stop methadone too early can lead to significantly increased rates of relapse, overdose, and even death. So we have to be very careful when someone is being taken off methadone. And ideally, right, the patient or the client should only be taken off methadone when they say they are ready and at the pace that they feel comfortable with. But of course, right, there's instances where that's not possible. People get kicked out of methadone programs. There's, in the past, been a really problematic dynamic of judges in certain regions of the country asking people to stop using methadone in order to comply with whatever the judge wants, and that's a really problematic practice that should really only be decided between the prescriber of methadone and the patient, and maybe their psychosocial support staff. And sometimes regions have also limited methadone in terms of what Medicaid will pay for, and that's also not an evidence-based practice. So we don't know what the ideal length is. We know, short-term use, 4 weeks, 6 weeks does not have very good outcomes. That typically it's 6 months, a year is like the minimum that someone can be on methadone, because, right, we're trying to move them from chaotic use, severe opioid use disorder, get their lives in order, and then maybe they can start to taper or titrate off the methadone. Buprenorphine is, of course, similar to how methadone works. It's an opioid as well, partial opioid agonist, so it's less strong as methadone. I mentioned that they're both called OAT. One of the benefits of buprenorphine is that it's less regulated than methadone. So there's kind of a lower burden on patients for access. Most of you probably know buprenorphine by its brand name, Suboxone. This is actually how a lot of clients talk about buprenorphine, even if they're not actually taking Suboxone, just because Suboxone is easier to say. They might be on Subutex or just, very generic, generic buprenorphine and calling it Suboxone, but it might not actually be Suboxone. Suboxone is a product that combines buprenorphine and naloxone, and the naloxone is only activated if the individual crushes or tries to liquefy the medication, and that's sort of doing it as what's called an abuse deterrent. And I'm putting that in quotes because, again, we don't like to use the word abuse, but that was sort of why it was originally formulated like that, is we don't want people to try and get a stronger effect, right, from their buprenorphine. So if we add naloxone, they can't, try to snort it or inject it to try and get that stronger effect. If you orally take Suboxone, the naloxone does not work, right? It does not activate. Okay, so patients are encouraged to stay on buprenorphine as long as it helps them. Like methadone, there's no optimal treatment length for buprenorphine, but we do know taking people off it too soon increases their risk of overdose and death and relapse. So you have to be very careful when titrating someone off of buprenorphine. It needs to be a slow process that the patient wants to do. I mentioned that it's less regulated than methadone. So methadone, of course, people typically at the beginning in this country, not in every country this is the case, but in the U.S., people have to come in for daily dosing until they establish a long record of adherence, after which they can get carries or take-home doses. But it takes a long time to work up to carries and take-home doses. I think it takes about 2 years to work up to 3 weeks of take-home doses. So that means you don't have to come in every day. You get 3 weeks of medication to take with you. Buprenorphine, the advantage is it's sort of treated like a regular prescription. Of course, physicians have to get a special training waiver to prescribe it. But in terms of patient experience, it's a little less, it's less segregated from like the typical healthcare sector. You can go to a regular pharmacy and pick it up. You get a monthly prescription, and it's sort of, no one necessarily knows why you're going to the pharmacy versus a methadone program. That facility typically has a standalone methadone facility program where someone has to go. So sort of in rural communities, that can be a little problematic if they even have a methadone facility, but to have your neighbors and community members sort of see you standing in line waiting for methadone can be somewhat stigmatizing. In other countries, methadone is dispensed at a regular community pharmacy. This is sort of a unique feature of the United States. Naltrexone is used, of course, for both opioid use disorders and alcohol use disorders. But for opioid use disorders, it's really just the extended release injectable naltrexone that goes by the brand name Vivitrol that's recommended for opioid use disorders. The daily pill is a little bit less effective for opioid use disorders. So the American Society of Addiction Medicine, their guidelines suggest the extended release 30-day injectable instead. It's not an opioid. It just blocks the effects of opioids as well as euphoric effects of alcohol. And it's recommended not for everyone, though, who has an opioid use disorder. It's really recommended for people who are less severe in their addiction and they want to reduce their chance of relapse, but they don't have high physical dependence on opioids because, unlike buprenorphine and methadone, it does not actually satiate the physical dependence on opioids. It just blocks the effects of opioids. So it's good for someone who maybe has a mild opioid use disorder or is very, very highly motivated in their treatment and recovery goals. For someone who's less ready, this is a less effective drug. So are these medications effective? Yes. Buprenorphine and methadone are especially effective. They're actually considered the gold standard of care for opioid use disorders, especially when combined with counseling. I mentioned that we don't want to sort of make our ideas about medication treatment as contingent upon counseling. But that said, counseling is important. It is recommended in the clinical guidelines to do counseling and medication treatment. But there are sort of like new programs, sometimes called medication first programs, that do provide low threshold medication, which means that they offer individuals buprenorphine or methadone without requiring counseling. And that has been shown to increase access and retention among people who really struggle to stay in methadone and buprenorphine programs that require counseling. This doesn't mean don't give them counseling and don't have psychosocial services available, but some methadone facilities will discharge patients who don't want to do the counseling and keep missing counseling appointments. Well, for those individuals, a medication first program is often a good idea. But unfortunately, these are not that common in the United States. These are more experimental programs at universities where we're sort of researching how these work. So there's not many of these in the United States, but they're actually very common programs in other countries. These medications are considered more effective than just doing counseling and not giving medications in terms of retaining people in treatment and reducing their illicit behaviors, so both drug use and criminal activities. So this is just one study, but it was a really big study in Massachusetts that showed the number of relapses people experienced in Mass Health, that's a Massachusetts healthcare system, who received treatment for opioid addiction. And this is just from 7 years or so of data, but it has over 56,000 patients in it. And what they found is that people who do not have any opioid agonist therapy, so and just behavioral health treatment, so just psychosocial services, that their relapse rate is much higher, right? So that's the green line, compared to buprenorphine and methadone, which were pretty comparable. The rate of relapse for those groups in the study were much lower. And so it just showed that for a lot of people with opioid use disorders, that these two medications really do reduce their risk of relapse and subsequently thus, reduce their risk of overdose and death as well. So is naltrexone effective? Yes. I don't want to down talk naltrexone, but we also have to be careful in how you're using naltrexone. So new studies do show it reduces cravings for opioids, and it does reduce illicit drug use, but it is less effective than methadone and buprenorphine. So, and this is because it requires a 7 to 10 day opioid detox period. So you can't have them on anything during that period before they can take their naltrexone. because otherwise, right, the individual, if they just take naltrexone the day after they've, taken heroin and they're dependent on heroin, they would be thrown into withdrawal. So during that 7 to 10-day detox period, people are at heightened risk of relapse and overdose. However, once someone is able to complete that, if they are and they're able to get started on naltrexone, then actually naltrexone has really good outcomes. But it's that 7 to 10-day detox that if we're just comparing naltrexone to the other two, it just doesn't perform as well. But after that detox, they do perform pretty similarly. Receiving counseling and naltrexone, of course, is still more effective than counseling alone. So if an individual, for example, cannot be on methadone or buprenorphine because maybe they're a healthcare professional and they're licensed, and the state licensing boards tend to not let nurses, physicians, etc., use methadone and buprenorphine, naltrexone is a good alternative. It's better than no medication for most people who have an opioid addiction. Okay. So I wanted to ask about the acceptability of medication treatment. So I wanted to ask, which of the 3 medications do you consider acceptable treatments for a society? So not asking, do you want to refer people to these, but do you think these should be available in a community? Which of them do you think are acceptable to provide in your community? Select multiple if you think more than one is an acceptable medication treatment. So I will say, as you guys are answering this, that there is a lot of debate actually about the restricting people who work in medical professions from using methadone and buprenorphine. There's been some NPR stories on it. There's a lot of talk on Twitter about people who are nurses or physicians who want to be able to use these, the gold standard of care for opioid addiction. They want to be able to use methadone or buprenorphine treatment, but they're not allowed because they can't get their license back if they use that treatment. In New Mexico, our licensing board does not allow medical professionals to be treated with anything other than naltrexone. But the question is that fair? If these are the gold standard of care, is it fair to bar entire professions from accessing this treatment? Mindy, I also wanted to invite you to say anything you wanted about these medications as people are answering the poll. You're muted if you're trying to talk. Some people have also said, you can sell methadone and buprenorphine on the street. These can be easily diverted medications. And I would say all of the research on diversion mostly finds that people divert medications because, they're making money, they're poor, and that people buy them on the illicit market because they don't have access to treatment. So that more than anything, this is like an illicit market for treatment more than it is an illicit market to have like party drugs or reach euphoria, right? So that probably the worry about diversion is overblown. But people can overdose, especially on methadone. Buprenorphine is unlikely, but methadone, you can overdose on methadone. So we're not saying no regulation is needed, but that when we worry about diversion, maybe our focus should be on how do we improve access to treatment, and that would actually probably better reduce diversion. Okay, so here's what people said. So naltrexone is considered buprenorphine, is considered the most acceptable, followed by naltrexone or Vivitrol, and last is methadone. I would also be interested to hear maybe some of people's worries or concerns about methadone or buprenorphine or naltrexone that maybe make you less interested in having those available in your community. If you want to put that in the chat. I also want to ask a second question now, which is now I'm asking you as as professionals. So utilizing medications and harm reduction in your own work. So which of the harm reduction interventions and medication treatments would you be willing to connect your clients or patients to? And you can select multiple if you wish. So now I'm not asking about sort of this more abstract, in your community, is this an acceptable thing to have? But you as an individual, is this an acceptable thing for you to work with? Would you want to connect patients or clients to? And I understand, of course, there might be some legal barriers to which you're allowed to engage with. And you could also explain some of that in the chat. Obviously, safe consumption sites are not yet really established, so that could be a barrier. But also, are there any sort of agency policies that mean you can't do this even if you wanted to? That would be interesting to know about.
Dr. Madden, there was a comment that this person thinks that certain medications keep people addicted.
Yeah, okay. So if we're thinking about what it means to be, and if Mindy wants to chime in here too, what it means to be addicted to opioids, right? They have to meet the 11 DSM-5 criteria, which include things, like disrupting your work life because you're using opioids. It's not just physical dependence. What a lot of people who work in medication treatment and harm reduction would say is that once someone is actually on these medications, yes, they still have a physical dependence to opioids, but a lot of those other criteria are actually going to go down or go away. Like they're actually going to be more likely to find employment and be able to keep a job. They'll be less likely to do things that are harmful to themselves or to get drugs. So what a lot of us would say is that actually you reduce the clinical indications of addiction when you use these medications. And yes, there's physical dependence, but physical dependence alone is not enough to be an addiction. Mindy, do you want to add?
Yeah, so I used to be a very abstinence-based therapist, right? And I felt the same. I felt like medications for opioid addiction were really, that they were a crutch. And what I have learned, though, is that it really just addresses the dependency piece, because opiates are different than like cocaine and methamphetamines. That way there's such that physical dependence, and it is the thing that even when people want to quit, it's so hard to because of that physical dependence. And I've also noticed as a provider, it gets people's brains clearer so that they're able to, they're able to engage in treatment better. Right? People who use drugs can also engage in treatment, but so I think that we have to be really careful, because when we stigmatize or demonstrate bias toward medications for opioid use disorder, we deter people from utilizing them. And I've seen plenty of people die that should have been on medication that were not, because of the shame piece of it. And also, if we look at data, we can see that the amount of people who divert medications are not as many as people think, not even close. And then when you ask yourself, why is somebody diverting medication? People divert medication to other people who are trying to get sober who don't have access to the medication. So I think those are all important things we need to keep in mind when we're thinking about medication-assisted therapies.
Great. So I'm seeing the poll results. So it seems like the most acceptable intervention is buprenorphine or Suboxone, followed by naltrexone or Vivitrol, and then naloxone distribution. The least acceptable is sort of safe consumption sites, and then sort of somewhere in between is syringe distribution and methadone treatment. So this is just in terms of your own work, which, your own work might have limits in what you could do anyway. So this is necessarily whether you think it's acceptable. So I saw that there was other mentions in the chat. Let's see. Okay, so someone said, I have heard of more instances of people taking too much methadone in particular, and have observed people nodding off when taking methadone more than Suboxone. I believe that patients should have a choice either way. I'm just concerned as it appeared overprescribed. Yeah, so I would say just methadone services are just like any other health services. They're sort of like good prescribers and facilities that are really responsible, and there's ones that are less responsible and less good. And I don't think that necessarily falls along public-private lines. So, I think some people would disagree with me there, where they would say private methadone facilities are less good than public ones. I don't think that's necessarily true. But, yeah, so I said before that for the nodding off, yes, nodding off can happen. My guess would be the best thing to do would be to talk to the client about what else they've taken, where they have their dosing schedule, because there's a problem also with how we induct people on methadone, where we start them really low and we won't bring them up to a higher level immediately. And so people are going to start to go through a withdrawal, so they're going to use heroin on top. So if they're early in their induction, some of that might be them using heroin or whatever illicit opioid on top of their methadone treatment while they're getting the dosing right. Or it might be them using benzodiazepines, it might be them using alcohol on top, it might be them being tired and thinking therapy or the meeting is boring. To be honest.
Yeah, it absolutely could be them taking their methadone as prescribed. And if you have groups in the morning, because this used to happen to me all the time when I worked at First Step House, right? It used to happen to my guys all the time because the ones who go and dose on methadone, they dose in the morning. And so when they come back and they're starting group, they just dosed at 6 a.m. and they're starting group at 8 a.m. That's an easy time. I mean, group, I've been to group a lot, and, not as a provider, as a client, even in like, it is sometimes hard not to fall asleep in group, but then when you've been given a medication that is a downer, that also can help, or that can also hinder somebody's ability to just stay awake in group. But I've also found if you're using good prescribers, and it's beyond the point of when they're first stabilizing on their dose, because when people are first stabilizing, that just happens, right? But when they're stabilized and that's happening, the provider should change their dose, and good providers will, because that's not the goal. The goal is not for them to be knotted out.
Exactly. Yes. Thank you, Mindy. So someone else said, I've heard of more instances of people taking too much methadone, and I've observed people nodding off. Oh, wait, I'm sorry, that's the same one. Almost all the clients who have used methadone in the past reported abusing it alongside or convincing their methadone prescriber to increase the dose to an extreme amount. They've all said it was not helpful overall, in some cases prolong their addiction. Yeah, so there's definitely like poor prescribing practices, just as in there's poor prescribing practices of people who prescribe anything. And not every physician is up to date on best practices, unfortunately. I would say maybe that individual should find a different facility with a better prescriber and, staff that are more attentive. And yes, people do sort of try to do things to get a higher dose, of course. But I would also pose this question: is them being on a higher dose of methadone safer than them using illicit fentanyl or heroin on the street? I would argue yes. We also think about what is the comparison. Compared to what they were doing before, even a dose of methadone is a little too high and they're very drowsy from it, is a safer alternative than what they were doing in the past. And yes, it takes longer than to titrate fully off of methadone over time. The higher your dose, the longer it's going to take to eventually get off methadone if that's what you want. But some clients, have used methadone for 30, 40 years, and that's fine for them. There's no time limit on this medication.
And we have some other comments, Dr. Madden. In Florida, Medicaid pays for methadone treatment, and since young women who get pregnant are automatically given Medicaid if they get pregnant. So at the methadone clinic, you will see many young women who are pregnant, so they will get Medicaid to pay for methadone. Also, my clients have told me that the withdrawal from methadone is severely difficult, more difficult than from Vivitrol or buprenorphine.
Yeah, so Vivitrol doesn't have a withdrawal, but buprenorphine, yes, because they're different medications. Methadone is a full agonist. It has a stronger effect. It takes longer to titrate off of. It does not mean it's impossible. I have multiple friends in Albuquerque who I worked with in research who were former methadone patients who had successfully titrated off from a high dose. It just takes longer. It doesn't mean it's not possible. And yes, it's easier with buprenorphine, but especially now with fentanyl, which is so much stronger than black tar heroin, you're going to have people who are maybe not treated effectively with buprenorphine because it's not as strong. That individual might need methadone, and it's not a failure or a problem for it to take longer to titrate off when they get to that point. That's okay. It's not the end of the world. Probably pressuring people to do it faster is part of what, results in the failure, not necessarily that, it taking a long time is a problem. In terms of pregnant people, yes, pregnant people who are addicted to opioids, the standard of care for them is methadone or buprenorphine, either one, not Suboxone because we don't know the effect of naloxone on pregnancy. That is the standard of care because if you compare that to an individual using illicit opioids, that person using illicit opioids has a much higher chance of overdose, the child being born with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. That risk is higher for someone using illicit opioids than it is for someone who's using methadone or buprenorphine. You greatly reduce all the bad outcomes that could happen, low birth weight, preterm birth as well, if someone's on those medications. You might say, well, isn't the safest thing to have them stop use altogether? Well, yes, but not everyone's capable of doing that. That's not the comparison group. The comparison group is to what they were doing before treatment.
Thank you. We also have a couple other comments. Clinical practice has seen improved successful outcomes providing the medications with other interventions. And then we have a question, have these harm reduction questions been proposed to persons using substances to see which options they would utilize?
They should be. They should be being presented to people when they enter into treatment as to what kind of treatment they want to pursue. And medication-assisted treatment is it's not appropriate for everybody. I do know people who they just want a legitimate way to kind of just stay loaded, which I agree with Erin, though, that's still safer. But not all people, methadone detox is worse than like heroin or pills. So like it's not appropriate for everybody, and it's not what everybody wants to do. So I think all people should be being given these different options as soon as they're considering recovery.
Yeah, I think everyone, that I know would advocate for a patient-centered approach to this. If the individual does not want to be on methadone because they're worried about eventually not being able to titrate off, okay, then then suggest buprenorphine, suggest naltrexone. No one is advocating in harm reduction to force anyone on any medication. It should be patient-centered, absolutely.
Okay, a couple other comments. I have worked in a mental health center which uses Vivitrol, and it does help. I've recommended people using heroin to explore buprenorphine if they could afford the cost. We have a psychiatrist certified to prescribe it, so helpful. Many I have worked with in the past will switch to a non-opioid to use, although it is not their drug of choice, along with methadone.
I'm not sure I totally understand the last one, but yeah, I mean, buprenorphine and methadone work equally well in most of the clinical trials. Ideally both can be offered because there's sort of different advantages to each. Someone who is pretty stable in their social life, can afford buprenorphine, that's a good client for buprenorphine. Someone who maybe doesn't have, $300 to $400 a month to pay up front for buprenorphine, someone who wants more structure, and someone who's more, higher physical dependence, they're a better candidate for methadone. Someone who's very motivated, good candidate for naltrexone. There's all sorts of reasons why someone should be on any given medication, and clients ideally would be given full information about each one and then help to make the decision of which works best for them. In terms of some of the other harm reduction questions, are those asked people who use substances? In general, people who use substances, yes, want to use in safe spaces. They want access to unused syringes. These are pretty popular programs for people who use drugs, yes. Okay, so I think in the sake of time, we'll move on to talk about some of the barriers to accessing these types of services. And this is a lot of what my research deals with. So there's 4 primary barriers. The first is cost, second is lack of information, and then the last 2 have to do with stigma. So in terms of cost, although there's a lot of harm reduction programs that offer free services, so Mindy's group, Utah Harm Reduction Coalition, offers free services. When it comes to medication treatment, things get pretty expensive pretty fast. So methadone, depending on where you are, depending on insurance coverage, et cetera, it can cost you $13 and $15 a day. Naltrexone, injectable naltrexone is really expensive, over $1,000 a month. Buprenorphine is about $350 a month. And insurance can cover some of these, Medicaid covers some of these, but sometimes it doesn't. Mindy, did you want to add?
No.
Okay.
Go ahead.
Okay. So for uninsured patients, this is obviously can be prohibitively expensive. But there's also a population who is what we call underinsured, which means on paper they have insurance, but their deductible or their copay is too high for them to actually utilize their insurance to get access to treatment. And we actually have a percentage of your income that would need to be underinsured. So we have a real definition of that, and that's a big problem with that population. Insured patients, even though who can use their insurance for this, there's a cost related to traveling to get services, taking time away from work to do so, et cetera. So cost is a real barrier. Also, lack of information. A lot of people in the public, so the family members of clients and patients, clients and patients themselves, they get information sometimes about treatment from each other. Of course, people who use drugs share information about treatment, but people are also getting their information from the media and how the media portrays treatment, which is usually not the evidence-based interventions. They usually actually only show abstinence-based interventions, which may actually be not be evidence-based practice for the individual and their sort of behaviors and their level of addiction. So, for example, there's a lot of reality TV shows, for example, like Dr. Drew, and the way that they talk about medication treatment or harm reduction is extremely negative and not evidence-based in their critique. So this lack of information can fuel stigma towards harm reduction and delay patient access to services. There's actually a lot of research that shows that clients will actually delay starting treatment because of negative statements made by their family and friends about medication treatment or about harm reduction services. So what people say matters, right? What people believe matters. Stigma, of course, can also be that barrier. Stigma can happen towards people with addiction conditions, so towards people who use drugs. And of course, stigma is a sociological term. It means when a person or group experiences prejudice, so negative thoughts, or discrimination, negative actions, because in a society because of a particular characteristic. So people are stigmatized, because of substance use, because of mental illness, right? But this is not something that's unique to substance use. But stigma towards people who use drugs comes in a lot of forms, and it has serious consequences. So people being denied care in emergency departments, people being called a junkie, being denied a job because of a past STD diagnosis, these are all types of stigma, ways stigmas are enacted. The effects of this can be hurt feelings, right, emotional distress, but that doesn't mean it's just hurt feelings, we don't care about it. Emotional distress leads to worse health outcomes because stress on the body, stress on the mind leads to worse health outcomes, but also can lead to really tangible, concrete problems like housing discrimination and lead to homelessness. It can also lead to people avoiding treatment, which I mentioned in the last slide. I also want to point out that stigma does not just exist towards people who use drugs, it also exists towards harm reduction and medication treatment themselves. And it is different and it is not totally comparable to that stigma towards people who use drugs because of what they do and because of their addiction. Individuals might be shamed for using harm reduction programs or using medication treatment because individuals maybe think the only legitimate step to recovery is through abstinent treatment programs. So this stigma actually at times comes from people who work in treatment, and this is what a lot of my research is on, is that when I go out and talk to people in treatment communities who are doing treatment work, what I find is that they talk about urging patients to stop medication treatment, regardless of that person's stage of recovery, even if they're really early on. I also have found people talk about denying counseling services to people who use medication treatment or still use illicit drugs. They say, you're not welcome at this facility. You're going to derail our other clients. Right, and this stigma is really problematic because it can result in delaying medication initiation, hiding harm reduction or medication use from friends or family or employers, so lying, and stopping medication treatment prematurely, which puts people at risk of overdose, relapse, and death. So we're going to switch gears a little bit and talk about how harm reduction, because this was really something we wanted to get to. We only have a few minutes left. So treatment and harm reduction can be complementary approaches. I'm going to hand this over to Mindy, I think, this part, yeah.
Okay. Well, thank you very much, Fred. Okay. So the common misperceptions around harm reduction is one of them, harm reduction encourages drug use. And I've talked about this when I've been presenting, and so has Erin. I don't encourage substance use. I also don't tell people that they're bad if they do that. Everybody seeks to feel better. Like everybody does it, and how people do it and what that looks like is where the problems come in. I want people to be alive and healthy and happy and realize their greatest potential, and I don't really see how that works when you're smoking crack. So I certainly don't encourage them. Harm reduction underestimates what people who use drugs are capable of achieving. That's not true either. We actually believe that people are capable of making good choices despite when they're making not so great choices. So I think the harm reduction is actually far more empowering than an abstinence-only method or line of thought. Buprenorphine and methadone are the same as heroin. No, they're not. We don't see people typically, robbing banks or doing some of the things that people do to get heroin when they're on methadone or Suboxone. We see people obtaining employment, housing, and making positive strides forward in their life for the vast majority of people who are on medication-assisted therapy. Medication-assisted therapy should only be used for a short time. When I hear people say that, I just ask them if they're a doctor, because all of us who are not doctors need to just refrain from interfering with prescription medications. And I would say that most prescribers, actually, unless they're a prescriber of Suboxone or methadone, that they also should refrain from sharing their opinion about medication, because it's outside of all of our scope of practice, including a prescriber who does not specifically prescribe methadone or Suboxone. Methadone makes people so drowsy they look high. I feel like we already addressed that. That can happen, and it can also be addressed. So many of the myths about harm reduction and medication-assisted therapies make people think these approaches to addiction cannot work with other treatment modules, but I've seen them work plenty. Like I said, it's not for everybody. There are plenty of people who abstinence is the best path for them. That was the best path for me. But we need to just allow people's paths to be what they are, and people engage in treatment the exact same as somebody who's abstinent. Like I do not have a different treatment plan based upon some, like a different path of treatment or different groups because somebody's on medication-assisted therapy. Harm reduction and medication-assisted therapies should be components of care that work together with other forms of treatment. I mean, we should always be looking to reduce harm in our clients' lives. And I said at the beginning that when we're working with people who are actively using substances, we have so many ways we can help reduce harm in their lives. There's so many things typically going wrong for them that, really we can cherry pick the areas that we're going to start helping with, because there is so many. And so I'd encourage you just to find those and work with them as quick as you can. These are just a couple graphs, and I know we're almost out of time here.
We can skip this, Mindy. Let's just go to the next one. Yeah. So
the poll.
Yeah.
Going back to you, Erin.
Okay, so we just wanted to ask, do you think, and we're going to, while you guys are answering this, we're going to talk about our ideas for how this can look. We wanted to ask, do you think harm reduction, medication treatment programs, and abstinence treatment could be integrated in ways where each kind of service complements the other? And I think, Mindy and I can add to this, but I think that there's sort of unnecessary friction, conflict between these approaches of substance use, because as Mindy said, abstinence is the right path. An abstinence-focused treatment program is the right path for some people, but it's also not for other people. Why is that necessarily a problem, that all of these sort of different services can coexist and work with the patients that are best suited for their programs? Why do we have to be conflicting with each other and stigmatizing each other? I would argue that we can and should be complementing each other. When a patient is wanting to go the abstinent route, they are referred from the methadone facility to an abstinent treatment program, and vice versa. Mindy, do you want to add?
Yeah, I would just, when there's a conflict between treatment and harm reduction or abstinence-based treatment versus medication-assisted treatment, that comes directly from the providers. So I'd really encourage us all as providers to check that in ourselves, because how is that client-centered care when we immediately are making the assumption that abstinence is the best path for someone? And that is what happens. So I would really encourage us all to check our biases and really support our clients in the way that we're supposed to ethically, which is through client-centered care. And then there shouldn't be conflicts, because it's well, this is what's best for this person according to them. This is what's best for this person according to them. These are the goals that they've set on their treatment plan, and these are the ways that we're achieving them. None of that has anything to do with abstinence versus, medication or harm reduction. All of those things, you can make goals within every one of those arenas.
Yeah, and I think also when we talk to people who use drugs about treatment, we need to be careful about how we talk about modalities that we don't work with, how we talk about methadone, how we talk about buprenorphine, how we talk about abstinence treatment. Because clients, of course, share information between each other, but they also listen to providers. And if you have a negative perception of something and pass that on to someone, that matters. And that does affect the way they think about their own care and what what is legitimate treatment and what is not. So I want to look at the poll. So most people said 59 out of 174 said, yes, I see how they can work together. 12 out of 174 said maybe, I see opportunities for integration or collaboration, and then 1% of 174 said no. So I think it's very promising that so many people said yes or maybe, because I don't know exactly what it looks like for these services to complement each other better than they do now, but I know that we're not doing very well in the treatment community with all of this. Mindy, do you want to add?
No, I think that covers it well.
Okay, so we would, if there's time to enter in the chat, we would love to hear what you think can be done to improve the complementing of medication treatment with abstinence treatment with harm reduction. How can we better integrate these services, talk to each other, connect clients to what works for them instead of assuming that only our approach works for a client? And something that happens too very often is people who work in treatment, who've been through treatment, sometimes think, well, what works for me will work for my clients. If I didn't need medication, you don't need medication. But sometimes also people are saying that who weren't even addicted to alcohol or opioids, so you don't have a medication option. So we also need to be careful about the role of our personal experience, which is a kind of expertise, but how we mobilize that and utilize that. We have to be careful that we also don't think about that the client is not the same as us. And we also need to think about the science and the evidence for each of these approaches. Well, people are adding to the chat, Mindy.
Let me look at the chat. It doesn't. I'm so not good at pulling up the chat.
So Karina says we're out of time. I love to see these answers. We'll look at them, and you are welcome to email us. We'll hand it over to Karina now.
Okay. Thanks for having us.
I'm pulling up some quick conclusion slides. If you want to take a quick picture of this slide, this is their email addresses if you have further questions. Sorry we couldn't get to everyone. You can also email me or call the office, and I'll be happy to share their information with you. When we conclude today's webinar, your browser will take you to an evaluation on our website. If you want to receive CE credits or a statement of credit for this event, you will need to complete the evaluation. But I do need to share with you that the site is down right now, so you may need to try back later to complete the evaluation. Also, you'll be prompted to register on or sign in to complete the evaluation. For CEs to be reported to CE broker, please remember to include your Florida license. And then after you register or sign in, you'll be directed to the evaluation. Again, the site is down, so you may need to try later. You will need to consider using the same email address when you register for the webinar to complete the evaluation. This helps us connect your attendance and your profile. You will also get a second opportunity to complete the evaluation through a follow-up email that you'll receive after the webinar is over. Again, the site is down, so you will need to try later if it doesn't come up for you right away. The evaluation will close on midnight on Friday, October the 30th, so please complete your evaluations by then. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. This process can take up to 30 days after the evaluation closes. And you will receive an email that, says, hey, your evaluation was completed. You can check for your credits under your profile. Again, it takes up to 30 days. We do want to thank our presenters for sharing the awesome information that they shared. And we also want to thank you for participating in today's webinar. As mentioned earlier, FADA's program for facilitating medication-assisted treatment for substance use disorder is funded by the Florida Legislature as administered by the Office of the State Courts Administrator. Have a great rest of your day, and Dr. Madden and Mindy, thank you so much again. Please hold for the evaluation.
Thank you all.
Thank you.